Gentlemen.
I can't see you, but I trust you're there, which is far better than the first year of our conference. In fact, the first year of our conference, when we first thought of having a conference that looked at the intersection of the biopharma world and the electronic health record world, I'm confident that we could have had that meeting in the back of my Ford hybrid. I have a hybrid because I live in California. If you don't, you're asked to leave. And this year we had a very snappy video. I hadn't seen it before. I hope you liked the video. I don't know if you noticed, Doug and I were back here. We were dancing. We were kind of, when I hit that glitch, I think I hurt my back. But I will recover. This morning we're going to talk about the words on the screen: EHR adoption, meaningful use, and patient engagement. And the words patient engagement, patient education, patient adherence are words you're going to hear a lot today. They were an honorable mention last year, but this year they're really moving into center stage. As we'll talk about today, for those of us who've been in healthcare for a few decades, you always hear the words, "It's all about the patient." But in reality, it's all about staying in business while caring for patients. And when you look at who really gets to vote on what happens in healthcare, frequently patient and patient engagement is relatively low on the list. This has changed dramatically in the last few years. In the last year, we'll talk about this. We'll talk about those trends and how EHRs you have to look at in the context of not just physician workflow, but also in terms of patient engagement and patient workflow. So with that, I'd like to reintroduce my friend Doug Gentile. Doug and I have known each other since medical school. He's one of those guys who sat in the front. He was right up here. If I was in the room, it was toward the back. But fortunately, we have really smart docs like Doug who continues to practice medicine. He continues in the emergency department on some periodic shifts, where he lives there in Vermont with his lovely family. And with that, I'd like to introduce Doug Gentile.
Thanks, Ed. Ed and I have actually done this sort of joint presentation thing a couple times now, and I was thinking that we're kind of like Huntley Brinkley, McNeil Lehrer. Andrew fortunately brought me down to earth this morning when he informed me that Cheech and Chong was a little closer to reality. Do we have I'm going to very briefly give an overview of EHR adoption and workflow. I think this is a topic most of you are probably familiar with at this point, and then we'll move on to patient portals. So most of you have probably seen slides like this showing really a pretty dramatic increase, as we just heard, in EHR adoption, in e-prescribing over the last couple of years. Again, if we look at the large practice market, 25 physicians and up, 75–80% of those practices have an EHR or are implementing one. And even at the small end of the market, the 1, 2, 3 doc practice, we're seeing pretty dramatic growth. And there are a lot of factors behind this increase. As an EHR vendor, I'd like to be able to stand up here and tell you that it's because physicians and hospitals are seeing enormous benefit from their EHR, and the doctors just can't wait to use it. And there's some of that, but the reality is we all know this is being driven by money, and particularly meaningful use money. CMS has distributed over $10 billion now in meaningful use incentives. And that's not a bad thing. After all, one of the primary purposes of the meaningful use program was to drive EHR adoption, and it's clearly working. For those of you who aren't in physician offices on a routine basis, when a practice implements an EHR, it completely changes the workflow. So as Ed mentioned, I still do 1 clinical shift a week in emergency medicine at the University of Vermont. And sadly, I can tell you that I spend a lot more time interacting with my computer, my EHR, than I do with the patients. It's where I go to do my documentation. It's where I look up information about patients. It's where I enter orders, look at results, where I do my billing, where I prepare discharge instructions for the patient. As a physician with an EHR, most of our work today is actually done in the EHR. We literally live in the EHR. And so it's potentially a pretty attractive vehicle for accessing physicians. The challenge, though, is that physicians are already overwhelmed. In the paper world, the challenge I had was not enough information. With a fully implemented EHR, I have the opposite problem. I have too much information. I don't hear physicians coming to me and saying, I need more information, if they have an EHR. Instead, they're saying, help me filter all this stuff so that I have just the information that I need to manage this patient on this particular day. So one of the biggest mistakes I see practices make when they implement an EHR is they compound this information overload by funneling work, all of the work, through the provider, work that in many cases the staff used to do. And they can do that because it's electronic and it's easy to funnel through the provider. This is a huge, huge mistake because inevitably the physician becomes a bottleneck. Inevitably they're staying 2-3 hours late. You've probably heard this if you've talked to physicians, to do all of this work. So what we want to do instead, of course, is to use the EHR to take work away from the physicians. Use the EHR to appropriately allocate work to the office staff so that they're able to work at the highest level of their capability and credentials. So what does all of this have to do with you guys? Well, pharmaceutical companies have traditionally focused their marketing dollars on pushing information to physicians, right? Through advertising, through detailing. I don't have to tell all of you that detailing is a tough business to be in today. So there's a temptation to want to push, to instead use the EHR to push that information to providers. What I would suggest to you is that in an environment of information overload, that's not likely to be successful. And if that information even hints at marketing, it's going to be rejected and be found to be annoying. So what if, instead of trying to use the EHR to push information to providers, you actually use technology to take some of this work away from providers, to help relieve the overburdened physicians? After all, even a simple prescription really isn't that simple. There's a lot of work associated with that prescription, particularly if it's a chronic medication, and particularly if you actually expect the patient to take that prescription. So what I'm suggesting is that instead of simply selling drugs, you think about selling solutions to clinical problems and clinical workflow. And we'll come back to that theme in a minute. So let's shift and talk a little bit about patient portals and patient engagement. We're seeing a similar increase in the adoption of patient portals all of a sudden. This is some data from Intuit showing their growth over the last year or two. In a recent survey by Chime, patient portals emerged as one of the top priorities for providers. So why this sudden interest? Well, it could be that physician practices and hospitals have decided they're really going to focus on the needs of patients. They're going to invest whatever it takes to deliver the latest and greatest tools to improve communication with their patients. Or maybe meaningful use actually has something to do with this as well. So if you look at the meaningful use stage 2 requirements, there are a lot of requirements around patient engagement. So on the provider side, there's a certification requirement to deliver info button enabled patient education. Everybody familiar with the info button concept? Anybody not familiar with info button concept? Looks like everyone is. So Ed's going to talk a little bit more about this in his section, but that information can be delivered via print. So if you're into killing trees and you like spending money on printer cartridges, you can print it out and give it to the patient, or you can push it to a patient portal. On the provider side, there are a number of requirements. So providers now have to use their EHR to deliver patient education to a minimum of 10% of their patients. They have to use the EHR to deliver reminders to patients about follow-up visits and preventive visits. They have to enable secure messaging between patients and providers, and a minimum of 5% of their patients actually have to use the secure messaging. And finally, they have to enable patients to view, download, and transmit their medical education, and again, there's a 5% threshold. Now, there's no actual requirement in meaningful use to use a patient portal, but virtually every physician practice, every hospital has concluded that a patient portal is the most effective and efficient way to deliver this. And if you look at the meaningful use timelines, physician attestation starts January 2014. Hospital attestation actually starts October 2013. That's not very far away. So it's not surprising that physicians and hospitals are moving quickly to implement patient portals because they've got to get their patients using the patient portal in order to meet these meaningful use requirements. So it's pretty clear that ONC, the Office of the National Coordinator, who publishes the meaningful use requirements, has decided that they want every physician practice and every hospital to have a patient portal. So why? Well, the cynics among us might think that it's all political. So imagine you're a senator or a congressperson and you're going back to talk to your constituents about sequestration. And somebody in the audience raises their hand and says, "You mean you're going to cut all these programs that are important to me, but you're going to pay rich doctors $40,000 apiece to implement an electronic health record? What's up with that?" I imagine that's a difficult conversation to have, unless you can turn it around and say, no, this meaningful use thing, it's not about rich doctors. It's about ensuring that you, my constituents, have easy access to your healthcare information. So I'm as cynical as anyone else, but I also know a number of the people at ONC, and this is not all political. There's a genuine belief at ONC that increasing patient engagement will lead to lower healthcare costs. And we'll examine the evidence for that in just a minute. There's also a vision at ONC of moving a lot of healthcare online. And this is a vision that's shared by many healthcare organizations. So we have clients today who are looking at the projected shortage of physicians, particularly primary care physicians. They're looking at the onslaught, if you will, of value-based care, and they're starting to think about how do we increase the average primary care physician panel from 2,000 patients today to 6,000 or even 8,000 in the future. You clearly can't do that with physical visits, so we're going to have to do the same thing that other industries have done, and we're going to have to move more of those transactions online. And there's actually pretty good evidence that 30 to 50% of office visits could be handled online without compromising care. And then finally, there is a belief at ONC, and by many in the industry, that more engaged patients will lead to better health, better quality of care, and better outcomes. And again, we'll look at the evidence for that in just a second. So patient portals aren't new. They've been around for at least 10 years. Some of you may not know that Ed actually started one of the first businesses to host a personal health record, met him back about 10 years ago, right? You'll notice he's no longer in that business. He was smart and sold it because it was a tough business back then. While early portals did provide some administrative efficiencies, there wasn't enough value there to really attract and hold a lot of patients. But of course, things have changed a lot in 10 years. So one big change that we just heard is that physicians are finally digitizing clinical information. That means they're now able to push that information to a patient portal. One of the early lessons of patient portals is that people are basically lazy. Okay? If they have to go and enter that information themselves, most of them simply won't bother to do it. They want it to be pushed to them automatically. Of course, expectations have also changed dramatically in the last 10 years. Today, patients want and expect to interact with their providers online. This was a survey done at the end of last year. It showed that 82% of baby boomers said communication from a healthcare professional via text, email, or voicemail was as helpful, if not more helpful, than an in-person conversation. This isn't Gen Xers, this is baby boomers. Okay, these are the folks who are going to be driving our healthcare costs over the next 20 years, and it's very clear that they want to be able to interact with their providers online and asynchronously. So what about cost, utilization, and outcomes? How many of you, let's forget about outcomes for a second, how many of you at least think patient portals will lower cost and utilization? Anybody? God, you guys are tough. I thought I was cynical or skeptical. But the truth is you have a right to be skeptical today because there's not a lot of evidence for this process. Some of the best data is actually coming out of Kaiser. So there were 2 early studies. So Kaiser Northwest, when they implemented their patient portal, I think they had a 6.7% decrease in outpatient visits. Kaiser California actually had a 20% decrease in outpatient visits. So pretty promising, right? Until this study came out at the end of last year from Kaiser, Colorado. Same electronic health record, same patient portal. They actually saw an increase in outpatient visits, and alarmingly, an increase in ER visits and hospitalizations. So talk about blowing a hole in your patient portal narrative. Okay, this was shocking. It's one study, so we shouldn't read too much into it, but I think it does point out that we're still really early in this process, and the evidence for benefit is pretty slim. So a lot of what we're doing today is betting on potential. Okay, and that's okay. There is an enormous amount of investment dollars, innovation, startup companies focused on the patient engagement arena now, and it's growing rapidly. Most of it is without any validation, however. So it's fine to experiment, we should, but we have to measure. Okay? We have to be sure that we're actually getting value out of these solutions. The reality is the features that will lead to lower cost, lower utilization, better outcomes are not known today. We don't know what works. So what should we think about when we think about patient portals? Well, personalization. Ed will talk more about this in his section, but if it's not personalized, it's not going to be utilized, is the general rule. Automation, we already heard that patients want this information to appear automatically. They don't want to have to go in and enter this. They don't want to have to do that work. Activation, so what tools will actually lead to a more activated patient? Mobile, this is like the. Okay, I read recently that either there now or soon will be more mobile devices than people on this planet. Anyone been to Africa in the last year or two? Do you see mobile devices there? I mean, it's amazing. We spent some time in a fairly remote town in Uganda 2 years ago, and everybody had a mobile. Not only did they have a mobile device, you could go up to these little roadside shacks and pay for things with your cell phone. So we expect a lot of the innovation in mobile healthcare to actually come from some of these third world countries. And then finally, social. I will admit to being a bit of a Luddite when it comes to Facebook and Twitter and those things, but we know the power of social networks in terms of affecting health behaviors. And so I have no doubt that social is going to be an important component of this. So is there a return on investment with patient portals today? Well, for providers, I think the answer is yes. And one of the easiest ROIs is getting rid of the paperwork. So doing what every other industry does, right? Okay, having people go online and enter that information. Everything from the ubiquitous but always annoying patient registration forms that we all fill out when we go into the physician offices, to taking review of systems and histories online, to having patients fill out standardized questionnaires online. All of those things can lead to a positive ROI. But what's in it for all of you guys? Well, very shortly, we're going to have millions of patients, millions of healthcare consumers going online and accessing their health information. So I think one of the opportunities is, again, to move from simply selling drugs to selling solutions to clinical problems. So what's our biggest problem in healthcare today? It's chronic disease, right? It's 75% of healthcare costs, 80% of prescriptions are related to chronic disease. To effectively manage chronic diseases, you have to do a whole lot of things that doctors are generally lousy at, okay? It's not enough anymore to simply prescribe a medication. You have to make sure that the patient's actually taking the medication and taking it correctly. It's not enough to hand a patient a printed static monograph, okay? You have to make sure that the patient actually understands their disease and understands the role of self-care. It's not enough to tell a patient to go diet and exercise. You have to actually be able to affect behavior change, okay? These are things that doctors don't do well and that they don't get paid to do, and there's probably a correlation there. But these are also things that are going to be increasingly important as we move to value-based care. So instead of selling a hypoglycemic drug, what if you actually sold an effective diabetes management solution that included a hypoglycemic drug? I think that's something that providers, patients, and payers would find attractive. So I think there's a big opportunity there. So finally, I'll leave you with one last thought. How many people use Mint.com? So a few people. So for those of you who don't, Mint.com basically aggregates financial information. So I've worked for a couple different hospitals, a couple different companies. I've got several different retirement plans. I have investments in a couple of different places. My wife's a doc. She's got her own retirement plans. And I'm just too darn lazy to try to bring all that information together. And so Mint.com does it for me. So who makes most healthcare decisions today? The wife, the mother, right? So imagine a 40-year-old female who has an OBGYN doctor. So actually, before I get there, the dominant model for patient portals today is what we call a tethered model, meaning that the portal is tethered to a specific electronic health record and typically to a specific practice or hospital. And that actually makes some sense when you think about the importance of being able to move data back and forth seamlessly. Okay, but think about now about this 40-year-old mother who has an OBGYN doctor who's got a patient portal. She's also got an internist because she has diabetes and hypertension who works in a different practice with a different EHR, with a different portal. Her kids go to a pediatrician, different practice, different portal. Her husband, when he actually goes to the doctor, goes across town to somebody he knows, different practice, different portal. Okay? And she's got elderly parents who she's trying to help manage their health care, and they spend half the year in Florida, different practice, different portal. Okay, the tethered model does not meet the needs of this healthcare consumer. And so I think there's a real opportunity for a Mint.com type solution, and maybe something that some of you will actually take up. So with that, I think I'm done, and I will turn it over to the exciting and interesting part of this conversation.
Thanks a lot. So I noticed the same people who vacation in Africa also use Mint. I guess if you're wealthy enough to vacation in Africa, you need a way to organize all that money. But for the rest of us, led by my colleague, for the rest of us, a reality check. So here's what we know. We absolutely, for a fact, know that providers have to provide patient education, and as Dr. Doug points out, it's going to go through the portal because it's just a lot easier. And in my opinion, the reason that the patients will register for the portal isn't because they want to register for a portal, and it isn't necessarily because they think they're going to get patient education, because guess what? They don't know they're going to get patient education. In fact, as we'll talk about in a minute, the providers still don't know they're about to provide patient education. They're going to register because they hate the clipboard. They're going to register because they hate phone tag. They're going to register because getting their lab results shouldn't take 3 or 4 days when they know they're available the next day. So for all those convenient reasons, they're going to register. And the practice is going to push them online because if they don't push them online, they won't be able to fulfill meaningful use. Not the patient education part, you could hand that out, but all the other components, you really need them on the portal. So once you get 10%, 20%, 30, 40%, obviously for most practices won't be 100%. And when we say patients, we're talking about patients and caregivers. So back in the days when I was running a very exciting patient portal business, which thank God we sold, about 25% of the patients were actually caregivers. So it was the mom, it was the elderly son or daughter of a frail elderly, it's those folks. So they're the ones who are going to be online. So all this is going to happen, but the docs don't have the time, the energy, or the inclination to write patient education materials, and they sure don't want to pay more for them, so we can pretty much guarantee that patient education will come from some other source. In the near term, the source will be their electronic health record. It will be the clinical component of the electronic health record that gives them the smorgasbord of things that they will choose, as they do in things like clinical decision support and drug lists and e-prescribing. It's that module. That's all they'll have to pick from. It has to be info button enabled. With time, there'll be more options, but that's where this is going to come from. And I think in our opinion, certainly at PDR, and I know Doug feels this way because he helps us out on an advisory board, and lots of people think, well, if the education and the reminders have to be specific to the patient, what are your opportunities? Well, it's either what's wrong with them or what are we doing about it? And I think there's a limit to the number of times you want to get the asthma or the diabetes monograph. It doesn't take a lot to remain diabetic. It takes a lot to organize your diabetes care, to remember to take your medications, to follow up for lab work, so on and so forth. So drugs change more often. They require more patient activity. They can be, as we'll talk about, automated, patient education for drugs automated with e-prescribing, and patient education can carry some of the services that the biopharma industry has traditionally made available and frankly wish they could provide to patients. Rich interactive programs, patient financial assistance, these kinds of things oftentimes are a light under a bushel basket. They're sitting at a website that isn't getting much traffic. And the truth is that to the average patient, the average doc, at the average point in their workflow, it's probably not relevant. But when I just wrote a prescription for a new medication, or I renewed your prescription, and I have a responsibility as a physician to send patient education, some patient education about the drug I wrote or renewed that included reminders and prompts and links to more information is probably about as high quality a service as I can provide, as opposed to whatever other education programs I might conjure up, because it's specific for that patient and that time in the patient's care. Now, if you look at how ONC, which is the federal government folks who run the EHR stuff, how they've envisioned patient education being enabled, it works something like this. So there's a simple view for a doc of a face sheet, and here's a couple drugs, and I have to say, oh boy, this is the 10th patient, so I got to send some patient education. So I'm going to click on that patient education, and I'm going to pull up one or more monographs about that drug or about that disease, and then I'm going to try to figure out if I sent this to the patient last time, or if this is duplicative, and then I got to figure out if I'm going to print it, and then I got to figure out if it's going to the portal, and then I got to close that thing down, and then I got to move on. And when you show that to busy docs and say you have to do this and remember to do it every 10th time, and I can tell you, having run a practice and run a group and run an IPA with 250 docs, they don't do anything every 10th time. It's either in workflow or it's not in workflow. This is pretty tough stuff. It's extra work, and the compensation is really, it's a requirement. There's no partial credit in meaningful use. You either make the cut or you don't. So this looks like extra work. And we, with the help of Doug and others, sort of said, gee, there's a better way to do that, which is to say, oops, go back up. Which is to say, when I prescribe, that's how automatic it is. I don't even have to touch the machine. Look at that. Isn't that fantastic? But the point is, there are certain steps in physician workflow that when I take a step as a doc, I should know someone else is taking a step. Someone else is doing the work for me, and this has been a natural extension of our work. You'll hear more about this, well, a little more about it at the conference, but we came up with this idea of PDR for patients, PDR Plus, as a natural extension of our work, but probably more importantly, a valuable service that hits right at the time when the docs are having to do this new work. And it kind of tips the model and says the info button is a way to access information, either to block it or to append a message, as opposed to requiring a whole bunch of extra steps. So we think that those automated in workflow provided by experts, the doc doesn't have to write it or pay extra for it, is probably the way to go. And if they want to, by exception, review a program, whether it's about a disease or a drug, that's the better use for the info button as opposed to making them do all the work. In fact, our market research on lots of docs says, here's what I'd really like. I want something free, I want it trusted. I don't want it to come from Acme, pretty good patient education source. It has to be a brand I know and trust, obviously info button enabled, integrated into my workflow, don't make me do any extra work, covering most of the drugs I use or the disease I treat, currently and regularly updated. The currently and regularly updated is particularly important for physicians because previously, the patient education, to the extent that it occurred, was a verbal discussion that was only documented to the extent the doc made a note one way or the other. Now, any information sent from the provider to the patient through the EHR is part of the medical record and will be subpoenaed. And either to defend the doc, to say, hey, look, the doc gave them all the appropriate information, or if it's old, stale, out of date, missed a box warning, what have you, it can be used against. Now, let's look at what's the awareness of docs that this requirement is coming in basically 6 months, and the answer is effectively zero. The hardest part for PDR in doing research on doc-provided patient education is to get them to understand that this is a requirement that's coming, because there's just no awareness. There's no awareness even today. And I think that Dr. Doug and our EHR colleagues with us today would agree that there's just so many other things that the docs have to know that until it's a week ahead of time, they're probably not going to focus on it. And the only ones who are really looking at this right now are EHRs and chief medical officers and CMIOs of larger organizations, because there's all this other noise in the marketplace. But it is an absolute requirement. And automation, as we mentioned, is key, and sourcing rich information, as Doug pointed out, from third-party experts is also key, because you don't want to send the same monograph multiple times. But once you start automating, then you have to say, are we going to send the same stuff over and over and over again? Or are we going to start looking at multiple messages, at interactive messages, at things that aren't just a static monograph? And that's really important if you look at the goals of things like the medical home, so-called Obamacare, ACOs, are all about patient engagement, changing the trajectory of the patient's care of themselves. One of the keys is customization. If you are wealthy enough to vacation in Africa and have Mint, you've probably gone to boutique hotels. And Doug tells me that when you go into these expensive places, that they learn your name straight away. They say, oh, Dr. Gentile, how lovely to see you. Don't bring him with you again. But they know your name. And why do they know your name? Because people like that. So you look again, the same study group that Doug had pointed out before, that increasingly when the patients are looking for information, if it's not tailored to them, if it doesn't include their name or the name of the provider or something like that, it drops much lower, and in some cases, 13% in this study said they would just ignore it out of the blocks. But if it looks like something that's torn out of a book, that's problematic. But there's really another subtlety here, and we've spent a lot of time with this, and again, I want to thank Doug and some people from ONC, FDA, some of our colleagues here from biopharm industry that have helped us think through some of this. But I'm not going to spend a whole lot of time on the detail here, and you have this slide, or will have this slide. But when you think about any kind of patient education, particularly drug education, if the drug education you get is for a prescription that was just written, and it's static, and it doesn't include your name, and it doesn't include the doc's name, and it says propranolol is a drug that is used to treat migraine headaches, hypertension, post-cardiac angina, blah, 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 that really isn't meaningful for you. What you want is a note that says, Dr. Gentile has renewed your prescription for propranolol for your migraine headaches. And the neat part is that all of that information, who prescribed, potentially the name of the patient, although that may not, it sort of depends on the details there. But what's the disease that we're treating? Is this a new prescription? Is this a renewal prescription? Really is important stuff if what you're trying to do is influence patient behavior, and that is the goal of this. So if you said, then what should the goal of the first or the message to the patient be? Well, if it's referential information that looks like it's torn out of a book, there's really no point to it aside from education. If it's in the context of prescription, the primary goal should be fill this prescription and take this medication as prescribed and follow up and have your lab work, all of that, because there's an intent. There's an authoritative tone. If you asked me, hey, we're thinking of going to Italy and for a vacation, I heard you've been to Italy. Well, I haven't been there either, but if they asked Doug, have you been to Italy? And he said, yes. Italy is a country on the southern Mediterranean with a population of 38 million, and you'd be like, well, that wouldn't surprise me. But that's not what you're looking for. You're sort of saying, it's binary. I'm going to Italy or I'm not going to Italy. It's the same for the patients. They need to know, what is the point here? The point is, I'm prescribing medication for you for this reason. You know who I am, I know who you are, and I want you to take this stuff. And until I tell you not to take it, you should continue to take it, you should do all the other stuff. So there's a real difference between the traditional patient education that's out there and referential patient education. That's certainly where we're trying to go, and we think that's where all these ACOs and everyone's trying to go. Not just here's some information about your disease, but here's some stuff that's important for you. And we think that the biopharma industry in particular are the experts, or the device folks, are the experts in their products and can be very helpful to docs, not only in the simple things like delivery of patient financial assistance in the context of an electronic health record, which should be low, or patient education, delivery of here's the prescription and here's the patient financial assistance, but also all the richer pieces, some of which exists out there but is being underutilized. Doug and I, and as I'd mentioned, a number of other folks participate in a not-for-profit group that writes guidelines in this space, and these are the guidelines, and some of the guidelines really match what we think should be the product approach. It should be specific, it should be designed to reduce provider time, so on and so forth. So a few words on beyond the requirement and beyond addressing the requirement. So one of the things that's so impressive is when you listen to provider groups talk about patient portals, it's like, oh, one more thing. I think it's probably now in the, oh, gee, I have to do it thing because the federal government mandated it. And yet, if you look at other industries, and we've all experienced this, they have moved our relationship with that industry or with that vendor online, and they have done it to provide a better experience or to lower their costs. They didn't do it because there was a federal mandate. They didn't take any federal mandates to create ATMs and online bankings and online check-in and mobile check-in and so forth. They did it because it saved, of consumer demand, and they did it because it saved them money. And we think this is the other piece. And once you start down this path, you start saying, what are all the cool things we can do with this portal that makes sense? And we have to do it, but why can't we turn this lemon into lemonade by looking at all the other cool stuff that we could do? Now, we already talked about improved practice efficiency, improved documentation and liability, but also improved patient satisfaction. And now patient satisfaction in several of these models is tied to income. It's tied to income actually in two ways. One is payer more dollars if your patient satisfaction scores are higher, but it's also more patients. I mean, United Airlines cares about their satisfaction, not because they get some federal reward for it, because satisfaction means filled seats, and in this case, obviously, you want patients to stick to your organization. So there's fulfillment that brings patients in, and then there's fulfillment of ACO, medical home requirements, and improved medication adherence, also tied to physician income in medical homes and likely in ACO models, because people who take their medications obviously have lowered healthcare costs. In fact, I don't think this is in here, for the first time late last year, the Congressional Budget Office published data saying that they now officially tie improvement in medication adherence to lowered healthcare costs, which is really important if you look at the Medicare Part D plans and some of the direction that Medicare is going. Obviously, you want them on board in rewarding medication adherence. So if you take a look at that, and I suspect everyone in biopharma knows this, that half of medications are taken incorrectly or not at all, and the fall-off rates are pretty steep, and provider-patient communication is, for almost all medications, a key to adherence. And there's great studies that show if the patient thinks that the doc knows or cares whether they take their medications, they're more likely to take it. When you do studies on adherence, if the patient knows they're being studied, the adherence rate goes through the roof. But that's not reality for most of it. That study effect doesn't percolate through. So to the extent you can automate these things, automate this engagement, and do it in a rich way that's customized, where you're pulling information from the EHR and pushing it back out, that really adds to the patient experience. Oh, there it is. There's that. I knew I'd read it somewhere. I know these slides like the back of my hand. Adherence really, and this new requirement aligns the incentive of a lot of folks. It aligns the incentive of a manufacturer who wants their drugs prescribed and taken as directed. It aligns the interest of the EHR, who wants to have programs that the docs can easily fulfill meaningful use. It obviously aligns the goals of CMS and other payers. And lastly, but probably, in theory, most importantly, it aligns the goals of the patient, because they're the ones who are healthier and can either get back to work or go on and enjoy their lives, or perhaps both. So this direction of medication adherence obviously is near and dear to our hearts at PDR, but we think that under any set of circumstances, this is going to be a key focus. So what are the other opportunities for patient engagement? Remember that patient engagement through a portal is not a one-way street. You can not only push information, you can pull information. And that's really key, and if you look at where ONC is going, that's going to be a key requirement. You not only get them to look at stuff you send to them, but you get them to respond. Simple things like patient satisfaction, other kinds of surveys. But you could ask patients, are you having any problems with your medication or with your new device? And if you are, pick from this list. That would be of tremendous value to the physician who wrote the prescription and to the manufacturer of the drug and device. It's very difficult for folks who have FDA manufactured products or FDA regulated products to get feedback from the end user, because it's typically manufacturer here, doc here, patient there, and you don't, unlike other industries, have the ability to leapfrog over and talk directly to the patient, at least not often enough. This, at least in an online format, opens up those doors. So obviously customized patient offerings, Allscripts and other EHRs already do some of this. You can have clinical trials offering that go on an anonymous basis, well, anonymous for the manufacturer, not for the doc, but can go to patients who would qualify for clinical trials. Obviously, the Mint model of aggregating fits right into that. Safety communications, this is an FDA goal that at some point in the future, when there's a problem with a drug or device, not just the docs are notified, but the patients who actually take the drug or who have the device would be notified. And if you follow meaningful use, propose meaningful use out in 3 and 4, this is a proposed list. If you're on the device side, device tracking, and I do some work with Brookings and FDA on this, so if you can start to see the patient over time, unlike the current situation where you get a device one time, you get an implant, and then you're lost to follow-up because you don't ever see the orthopedist again. Now, in theory, you can follow them over time. All of these are patient-friendly. For patients with device, they'd love to know more information about their device. I had a hip implant, and I haven't the slightest idea who the manufacturer was, what the lot number is, if it's been recalled. If they recall it, I'm not sure how they're going to get it back from me, but the point is I just plain don't know, and neither does folks who have a stent or anything else. They know very little about their drugs, and they know nothing about their devices, and this new connectivity can change all that. It really addresses what many of the folks have had, including, I think, the providers have had, is addressing an efficient way to attack the last mile problem. The last mile in telecom, obviously, is getting to those rural houses. In this case, it's actually getting to the patient. So, what are the take-homes here? So obviously, EHR adoption is there, and it sits in the middle of workflow. From the patient portal functionality, meaningful use requires patient engagement. It is not optional. It will occur. The docs do need help. They don't want to do more work. They don't want to pay more money. And they're looking for help, and a lot of the folks in the room here can be helpful to them. We certainly are at PDR, and we welcome the opportunity to collaborate with you in that. This is moving beyond billing efficiencies, is really moving to patient engagement. And ultimately, although we haven't convinced Doug yet, ultimately lower cost and have patients who are healthier and happier, and in theory that's why we're all here in the healthcare industry. We think this patient portal thing is going to make a big impact. We think it's actually flying a little under the radar screen right now. We wanted to kick off today talking about patient portals because we think it's not just going to percolate through this summit today, it's going to percolate through, and by next year's summit, we're going to be looking at a lot of data and a lot of feedback, and it's going to be a fun pivot for healthcare.